Start Cheja. So, good morning, students. So, everyone listening to the class, I hope everyone is listening to the class. So, due to some disturbance, we are not able to complete the topic previously. Regarding this issue, as a department of ENT, we felt very bad. So, I request you, please don't repeat this kind of things again. Okay, I'll talk to this later at the end of the class. At present, I have to complete the any question. Someone is asking some questions. Okay, so the difference between the vocal nodule and vocal polyp is vocal nodule is bilateral. Vocal nodule is bilateral. It is present at the junction of anterior 1/3 and posterior 2/3. Why it is present at the junction of anterior 1/3 and posterior 2/3? Because it is the site of maximum vibration of the vocal cord. Because of maximum vibration of the vocal cord, the vocal nodule is located at anterior 1/3 and posterior 2/3 of the vocal cord. So they asked the question previously in the PG entrance bit, where is the location of the vocal nodule? Is it located at the junction of anterior 1/3 and posterior 2/3? At the junction of anterior 2/3 and posterior 1/3? At the junction of anterior half and posterior half? None of the above. The answer to this question is at the junction of anterior 1/3 and posterior 2/3, because the reason is maximum vibration of the vocal cord is present at the junction of anterior 1/3 and the posterior 2/3. So for any vocal cord nodules, it may be vocal nodule, it may be vocal polyp, or it may be Reinke's edema. The investigation of choice is direct laryngoscopy. First investigation we will do in the OPD. We will use indirect laryngoscopy, IDL. What is indirect laryngoscopy? It is a mirror which is bayonet shaped. It is placed in the oral cavity and the mirror will be facing towards the larynx. So there are two types of mirrors in the ENT department. One is the indirect laryngoscope, IDL, and the second one is posterior rhinoscopy. So what is the difference between the indirect laryngoscopy and the posterior rhinoscopy? The posterior rhinoscopy is helpful to see the nasopharynx. It is helpful to see the nasopharynx. So it is called as posterior rhinoscopy, whereas indirect laryngoscopy, IDL, is helpful for seeing the vocal cords, and epiglottis. So when you want to see the adduction of the vocal cord, adduction means what? Add. If you want to see whether the vocal cords are adducting or not, what you will ask the patient to say? To see the adduction of the vocal cord? Can anybody answer? Excellent. Say your batch is very good batch. They are very brilliant people. One person, one girl, she scored 40 out of 40. This is very great thing. But the issue has happened. Some people, they are really spoiling the good name of your batch. Okay, you are very intelligent, very good batch. I hope you will get good marks in the exam and good entrance seat. Okay, so very good answer. So if you ask the patient to say E, the vocal cords will get adducted. So for adduction of the vocal cords, you will ask the patient to say E. But if you want to see the abduction of the vocal cords, what will ask the patient to say? Abduction means excellent. Take a deep breath. So if you want to take inspiration, the vocal cords must get separated and the air must enter into the larynx. So to see the abduction of the vocal cord, you'll ask the patient to take a deep breath. So by saying E and by taking a deep breath, you're able to see whether the vocal cords are adducted or abducted. All are adductors except one muscle, which is the abductor muscle. What is the abductor muscle? The only one abductor muscle of the vocal cord is excellent posterior trichoerectoid muscle. So in the PG entrance, they can give the question like, when you're examining the patient, you're asking the patient to say E. You're asking the patient to say take the deep breath. you are testing which muscle of the larynx. You are asking the patient to say, take the deep breath. So you are testing which muscle of the larynx. You are testing which muscle of the larynx. Can anyone answer? Excellent. It is posterior cricoarytenoid muscle. So see the application of the question. See the application of the question. How they are applying the question. They are not asking you the only adductor, only abductor of the vocal cord. They are not asking you the only abductor of the vocal cord. Indirectly, they are asking you by saying that if you ask the patient to take the deep breath by seeing in the indirect laryngoscopy, the which muscle you are testing. So the only abductor of the vocal cord, not adductor, only abductor of the vocal cord is posterior cricoarytenoid muscle. Okay, excellent answer. So vocal polyp. What is the vocal polyp? Is it unilateral or bilateral? The vocal polyp is unilateral in location. It is present at the junction of. It is present at the near the anterior commissure. It is present near the anterior commissure. So it is unilateral in location. So what is the symptoms? Any vocal nodule, vocal polyp, or rhinitis edema? You can blindly write the symptoms is hoarseness of voice. Hoarseness of voice. But if this large polyp, it goes into subglottic space. What is subglottis? From where to where does the subglottis extend? Subglottis extend అవుతుంది. The subglottis extends from the inferior surface of the vocal cords up to the lower border of the cricoid cartilage. So from the inferior surface of the vocal cord up to the lower border of the cricoid cartilage, it is called as subglottis. So if the polyp, it enters into subglottic space, it is obstructing the inspiration. So the patient will have respiratory distress and the patient will have respiratory obstruction and the patient will complain of dyspnea. So there won't be any dyspnea in vocal nodule, vocal polyp, vocal nodule or vocal rhinitis edema, but there is dyspnea in vocal polyp because the polyp which is pedunculated, if it is pedunculated, it enters into the subglottic space, so obstructing the respiratory system. So stridor is a characteristic feature of subglottic polyp. Subglottic polyp. Okay. So we discussed about the vocal nodule and vocal polyp. Surgery is microlaryngeal surgery. Okay. Now we'll speak about rhinitis edema. What is rhinitis edema? Rhinitis edema is also due to vocal abuse or using high pitch voice. So because of sudden vocal abuse, there is rupture of blood vessels in the rhinitis space. What is rhinitis space? Can anybody answer what is rhinitis space? So without completion of the question, you have answered. What is rhinitis space? Anybody? What is rhinitis space? Superficial layer of the lamina propria. Okay, excellent. Superficial layer of the lamina propria is called as rhinitis edema, rhinitis space. So any fluid accumulation in the rhinitis space, accumulation of fluid in the rhinitis space is called as, two persons has raised the hands. Okay, so any fluid accumulation in the rhinitis space, it is called as rhinitis edema. It is called as rhinitis edema. So rhinitis edema is nothing but it is accumulation of the fluid in the rhinitis space. So the reason is common for everything. For vocal nodule, vocal polyp, the reason is common. There is nothing but it is due to vocal abuse. It is because of smoking. Okay, so this rhinitis edema is a benign lesion. Okay, so this is the rhinitis space. The rhinitis space is subepithelial space. The epithelium of the vocal cord is lined by stratified squamous epithelium. Stratified squamous epithelium. Okay, below this space is the rhinitis space, which is a superficial layer of the lamina propria. So rupture of the blood vessels in the rhinitis space causes accumulation of the fluid in the subepithelial space, which is nothing, which is called as rhinitis edema. So there is no restriction in the rhinitis space. So the fluid accumulates from anterior commissure to the posterior commissure. So there is generalized swelling of the vocal cords in rhinitis edema. But in vocal nodule, it is a localized. Nodule is a localized swelling of the vocal cords. Whereas polyp is also localized swelling of the vocal cord. But rhinitis edema is a generalized swelling of the vocal cord from the anterior commissure to the posterior commissure. So what happens when you see the indirect laryngoscopy? So in indirect laryngoscopy, you will see bilateral edema of the vocal cord. The vocal cords are saggy. The vocal cords are saggy, and there is medial bulging of the vocal cords. The vocal cords will be bulging medially, showing a convexity. See, the bulging will be like this. showing convexity interiorly. Okay. See, this is the appearance of the Reinke's edema. The Reinke's edema is a generalized swelling involving the vocal cords. It is a generalized swelling involving the vocal cords from the anterior commissure to the posterior commissure. See the bulging medial convexity of the vocal cords, which gives rise to boggy appearance or bag of water appearance, bag of worms in general surgery. Where do you see bag of worms? This is bag of water appearance. Where do you see bag of worms? Can anybody answer? Bag of worm appearance. Okay, I'll give you a hint also. Bag of worm appearance in testis. Bag of worm appearance in testis. Excellent. Varicocele. Who is she? 17807141. Can you please name it? Name the person who has answered this question. 17807122 and 7141. Name. Monica. Excellent. Excellent. Wonderful, Monica. Please keep it up. You have Can you say what is the investigation of choice for varicocele testis? Investigation of choice. This is a Doppler scan. Doppler. Varicose means veins. So to see the veins, you will use Doppler scan. Excellent. So this is a bag of water. This is the bag of water. But there is bag of worms. Bag of worm appearance in testis. Bag of worm appearance in the testis is varicocele, but this is a bag of water, boggy appearance, bag of water appearance is Reinke's edema. So the vocal cords appears like bag of water appearance in following conditions. Options are vocal nodule, vocal polyp, and Reinke's edema. None of the above. What is the answer? The answer is Reinke's edema. Only in Reinke's edema, the vocal cords appear like bag of water. Why? It is a generalized swelling. The vocal cords are generalized swelling, not localized swelling like your vocal nodule or vocal polyp. It is a generalized swelling. The swelling extends from the anterior commissure to the posterior commissure. So it is a generalized swelling. So it gives rise to, Janavi also answered. Okay, nice, Janavi, keep it up. So the Reinke's edema gives rise to bag of water appearance. Okay, so what is the surgery? So what surgery you will do? You will do the surgery. The name is called as decortication surgery. What is decortication surgery? I will show you. See, you are giving incision from the anterior commissure to the posterior commissure. This is the incision what you are giving. This is the incision you are giving from anterior commissure to posterior commissure. Why are you giving incision from anterior commissure to posterior commissure? Because it is not a localized swelling. It is a generalized swelling. It extends from the anterior commissure to the posterior commissure. So you have to remove the disease from whole of the length of the vocal cords. So you are giving incision from the anterior commissure to the posterior commissure, and you are elevating the epithelial flap. Then you will see the edematous substance, edematous fluid in the Reinke space, and by using a suction cannula, you are removing the tissue, removing of the edematous tissue. This is the removal of the edematous tissue, and afterwards you are trimming the excess epithelium and you are draping it, re-draping it. So this surgery is called as decortication surgery. So decortication surgery is useful for Reinke's edema. So this is a boggy swelling of the vocal cords, and after elevation of the flap, you are removing the edematous tissue and you are trimming the excess tissue, excess epithelium, that is squamous epithelium, and you are placing it over the vocal cord. This type of surgery is called as decortication surgery. So this is a surgery. This is a pre-op surgery, pre-op photo before the surgery, and this is the post-op photo. So you are able to see a good space. There is no edema. You are able to see a good space after post-op surgery. Okay. So this is the image. This is the epithelium, squamous epithelium. This is a subepithelial space which is called as Reinke's space. You have given an incision in the subepithelial space, and you have kept a suction cannula, and you have sucked all the edematous tissue. After sucking off all the edematous tissue, you have trimmed the excess epithelium and you have draped over it. The remaining epithelium is draped over the raw surface. This surgery is called as decortication surgery in Reinke's edema. Okay. What is contact ulcer? Contact ulcer. Is it a true ulcer or a false ulcer? What is the ulcer? Can anybody answer? What is the ulcer? Ulcer and eprantum. What is the ulcer? Ulcer and Vishnu. What is the ulcer? Excellent. It is a disruption. It is a break, discontinuity. Wonderful. It is a disruption, break, discontinuity in the epithelium. See, the medical students must be like this only. They must be answering everything rather than giving rounds, circles, different types of images. Okay, the dignity of the medical student lies in how he answers the question. Okay, so it is a disruption in the discontinuation of the epithelium. So ulcers. So what is the most common site of peptic ulcer disease? Can anyone? What is the most common site of peptic ulcer disease? What is the most common site of peptic ulcer disease? Is it stomach or duodenum? Any answer? Answer something. First part of duodenum. The most common site of peptic ulcer disease is first part of duodenum. So what is the most common site of diabetic foot ulcer? Diabetic foot ulcer, most common site. It is at the heads of the metatarsal, foot. Diabetic foot antaru kada. So it is present at foot. It is at the heads of the metatarsus. Then what is the most common site of pressure ulcer or sore ulcer? Bed sore or pressure ulcer. What is the most common site? Yes, it is sacrum. Sacral region is the most common site of pressure ulcer. That is, what is the most common site of venous ulcer? Most common site of venous ulcer. Can anybody answer? Legs where? It is at the medial malleolus. It is at the region of medial malleolus is the most common site of venous ulcer. Then what is the most common site of arterial ulcer? It is most common site of arterial ulcer. The most common site of arterial ulcer is at the lateral malleolus. Arterial ulcer is at the lateral malleolus. So venous ulcer is at medial malleolus and arterial ulcer is at lateral malleolus and anterior surface of the leg. Okay. Whereas the pressure ulcer or bed sore is at present at the sacral region. Peptic ulcer disease most common site is first part of duodenum. So do you think is a contact ulcer is a ulcer or not? Is contact ulcer, is it ulcer or not? Is it ulcer or not? Yes, it is not ulcer. It is a false ulcer. Okay, it is not an ulcer. Contact ulcer is not a ulcer. It is a misnomer. What is the other name of contact ulcer? What is the other name of contact ulcer? It is pachyderma laryngitis. It is pachyderma laryngitis. So they'll ask the question. The contact ulcer, or they won't give contact ulcer. They'll say pachyderma laryngitis is vocal nodule, vocal polyp, Reinke's edema, leukoplakia. Last option is contact ulcer. So pachyderma laryngitis is a contact ulcer. It is a contact ulcer. It is not a true ulcer. It is a misnomer. It is a false ulcer. Okay, it is a false ulcer. It is a disruption in the overlying. It is not a disruption. There is no disruption in the overlying epithelium. Then what is the problem? There is a sausage-like lesion at site of mucoperichondrium covering the middle surface of the vocal process. So the vocal process, at the vocal process, there is swelling in the vocal process. It is because of thickening of the epithelium. It is nothing but it is thickening of the epithelium. What is epithelium? What epithelium is covering the vocal cord? It is a squamous epithelium. So the thickening of the squamous epithelium, which forms saucer-like lesion at the site of mucoperichondrium, is called as contact ulcer. It is called as contact ulcer. So contact ulcer is a thickening of the epithelium. The epithelium forms a granuloma-like structure. It forms a swelling. It forms a granuloma-like structure, which is called as contact ulcer. It is not a breach. It is a epithelium proliferation. It is epithelium proliferation, or it is a thickening of the epithelium rather than disruption of the epithelium, which is called as pachyderma laryngitis. Okay. So the causes are same: vocal abuse, gastric reflux. Okay, everything is same. Okay. So this is the contact ulcer at the posterior commissure. This is the contact ulcer. It is not a disruption. It is a epithelial proliferation. It is a epithelial proliferation which forms a nodular swelling at the site of vocal abuse at the posterior commissure, which is called as contact ulcer. So contact ulcer, most common site is posterior commissure. Okay, so this is at the posterior commissure. So you have seen all the lesions. Vocal nodule is present at the junction of anterior 1/3 and posterior 2/3, whereas this vocal polyp is present at the anterior commissure. But the only lesion which is present at the posterior commissure is your contact granuloma. Can anybody logically say why the contact ulcer in GERD is in the posterior commissure region? It is present as posterior commissure. Why it is present as posterior commissure? This is the anterior commissure. This is the posterior commissure. Why in GERD there is a lesion, there is a contact ulcer in the posterior commissure? Can anybody answer? Think logically. See, wonderful answer. 1780-7030. Who? Please mention the name. Please mention the name. 1780-7030. Can you mention the name, please? You don't want your name to be mentioned. Okay. Excellent answer. Excellent answer. Wonderful. Okay. So you're not mentioning the name. Leave it off. See, the esophagus is present posteriorly. The esophagus is present posteriorly. Silusha. Silusha. Wonderful answer, Silusha. So the esophagus is present posteriorly. So when the reflex occurs, the most common site which gets exposed is the posterior commissure region. So the posterior end of the vocal nodule, because of the reflex, it gets irritated. Because of the irritation, there is hyperplasia. There is a proliferation of the epithelium, which gives rise to this type of granuloma, which is called as contact granuloma. So contact granuloma is present in the posterior commissure in GERD because posterior commissure is close to esophagus. So whenever there is a reflex of the acid, it irritates the posterior 1/3 of the vocal cords, gives rise to contact granuloma. Contact granuloma. This logic catch cheyagalugute chalu. Okay. So treatment. What is the treatment? You give him voice therapy. Idantha manaku telisinde. Exam lo elago pulihara rasestam guarantee ga. So any vocal cord lesion like vocal polyp, vocal nodule, anything. If you don't know the answer, you can blindly write that the risk factor is smoking, voice abuse, okay, GERD. You can write for everything. After that, the treatment part, you can diagnostic part, you can write. You can use direct laryngoscopy. You can use indirect laryngoscopy. And for the treatment, you can say vocal. We can use for treatment process. We can use voice rest, anti-reflex drugs for contact granuloma. We can give relief from physiological stress, voice rest, steam inhalation. And for surgery, you can blindly write the surgery is microlaryngeal surgery. So this part is made easy. I think so. Okay. See, endoscopic excision or microlaryngeal surgery, we can remove it because this is a mushroom type shaped lesion. It is not ulcer. It is a mushroom shaped lesion. It is because of proliferation of the epithelium. So this is the, so now we'll talk about the intubation granuloma. So what is the risk factor for intubation granuloma? Intubation means what we'll use in the intubation. What is this tube called as? What is this tube? Can anybody say what is this tube which I am mentioning here? What is this tube? Endotracheal tube. So during intubation, we'll use endotracheal tube. So this endotracheal tube will cause friction in the vocal cord. Because of the friction in the vocal cord, there is formation of the granuloma. Granuloma is because of inflammation, because of this pressure or stress or stretching of the vocal cord or due to injury of the vocal cord epithelium, there is formation of granuloma. The healing occurs by formation of granulation tissue. This granulation tissue will accumulate to form a granuloma. So this granuloma after intubation is called as intubation granuloma. So it may be unilateral or bilateral. If the tube is larger in size, compared to the glottic space and compressing both the vocal cords, it gives rise to bilateral intubation granuloma. But if the tube is small and if the tube is compressing only on one side, that means the anesthesia station machine is kept on one side only, and the tube is supported and the tube is pulled towards one side, it leads to formation of granuloma on unilateral granuloma. It is formation of unilateral granuloma. So the intubation granuloma can be unilateral or bilateral. Depends on the size of the tube and because depends on the position of the tube. The intubation granuloma can be unilateral or it may be bilateral. So this is the one intubation granuloma. Okay. So this is a white plaque. So this is the regarding the intubation granuloma. So what is the management? Intubation granuloma. It is a mushroom shaped pedicled granuloma situated superiorly or medially on the vocal cord, detected 2 to 4 weeks after prolonged ventilation. So it is detected after 2 to 4 weeks of the prolonged ventilation. Okay. So it is because of long-term intubation and pressure necrosis which has given rise to reactive granuloma. So I have already discussed regarding this. So it is because of prolonged ventilation of 2 to 4 weeks which gives rise to friction injury to the vocal cords, which leads to healing process. During the healing process, it leads to formation of the reactive granuloma. So the underlying mechanism for intubation granuloma is pressure necrosis. So the underlying mechanism for intubation granuloma is pressure necrosis. So previously we have talked regarding all the ulcers. In these ulcers that you have seen the arterial ulcer, venous ulcer, you have seen the bed sore, and you have seen the gastric ulcer. In which ulcer there is a pressure necrosis? There is a mechanism of pressure necrosis. In which ulcer? Apart from intubation granuloma, which ulcer gives rise to pressure necrosis? It is the bed sore. Bed sore will give rise to pressure necrosis. Okay. So the treatment is same. You will use microlaryngeal surgery. You remove the intubation granuloma and you remove the excess epithelium, which is excess epithelium of the vocal cord, and you approximate the remaining of the vocal cord. This is a surgery. This is a microlaryngeal surgery in intubation granuloma. Okay. So what is vocal cord leukoplakia? What is leukoplakia? What is leukoplakia? Leukoplakia is a whitish covering of the vocal cord. Whitish covering on the upper surface of the vocal cord. Okay. Due to smoking or due to smoking. Is it a pre-malignant or malignant condition? Leukoplakia. It may turn into malignancy. It is a pre-malignant condition. So what you have to do? You have to do a surgery. You have to strip off the white covering. You have to strip out the leukoplakia from the upper surface of the vocal cords. Okay. If you won't remove, it will leads to what? Malignancy. Leukoplakia of the vocal cord leads to what malignancy? Carcinoma larynx or carcinoma glottis. Okay. Not only that, you advise the patient to quit smoking. You advise the patient to quit smoking. If you continue smoking, this leukoplakia, which is a pre-malignant condition, will land up into malignancy, which will land up into carcinoma larynx. So you'll ask the patient to quit the smoking and adopt the healthy habits rather than smoking and alcohol. Okay. So this is a whitish covering on the vocal cords. It may be unilateral or bilateral. Whitish covering on the vocal cord. This is a glottis. So you will take the biopsy by using the microlaryngeal surgery. You will take the biopsy from the vocal cords and you will send it for histopathological examination. If it comes out as a leukoplakia, you will tell the patient to quit smoking and you will ask the patient, you remove this leukoplakia, and afterwards you will tell the patient to take a conservative treatment. You will ask the patient to quit smoking, take B-complex tablets and do steam inhalation regularly so that this does not change into carcinoma larynx. Okay. See, this is the leukoplakia. We are excising the leukoplakia. That is, leukoplakia is present on the epithelium of the vocal cords. We are excising this epithelium, and not in the excising of the epithelium, we have to advise the patient not to start the smoking again. Please quit the smoking. You are landed up in a pre-malignant condition. So don't land up in a malignant condition. Okay. You will advise him. Advice is more important rather than surgery in leukoplakia. So laryngoscele. What is the laryngoscele? What is the laryngoscele? Same laryngoscele we have discussed this type of pathology in esophagus. What is that? What is that? Can anybody answer? Same we have discussed in the esophagus. We have same laryngoscele we have discussed in the esophagus. It is a type of diverticulum through a space. It is juncus diverticulum. So laryngoscele is also same like juncus diverticulum. Why the laryngoscele is happening? It is because of weakness in the larynx, which gives rise to outpoaching of the laryngeal framework, outpoaching of the laryngeal framework, giving rise to Laryngocele. So what is the most common site of laryngocele in the larynx? Most common site. It is a saccule. What is the other name of saccule? What is the other name of saccule? What is the other name of saccule? It is the ventricle of larynx. Ventricle of larynx or saccule, both are same. So students, can you guess why there is weakness in the saccule or ventricle? Why there is weakness? Why the laryngocele is not arising from other parts of the larynx? Why it is arising from the saccule or ventricle? What no covering? What there is no covering? What membrane? No membrane. See, the larynx is covered superiorly by an intrinsic membrane, which is called as quadrangular membrane. Quadrangular membrane extends from the false vocal cords up to the epiglottis, and the larynx from the true vocal cords up to the cricoid cartilage. There is a membrane which is called as cricovocal membrane. So the space between the true vocal cords and the false vocal cord is called as saccule space. It is called as saccule or ventricle. This is the true vocal cords. See, this is the true vocal cords. This is the false vocal cords. From the true vocal cords, we have quadrangular membrane above. From the false vocal cords, we have quadrangular membrane above. From the true vocal cords, we have cricovocal membrane below. So this space, which is not covered by any membrane, it is called as saccule or ventricle. So outpoaching of the mucous membrane from this space is called as laryngocele. It is called as laryngocele. So what is laryngocele? Laryngocele is because of increased pressure in the larynx. Why we are not getting the laryngocele? Because in the aged people, in the old age people, there is still weakness in the larynx, more weakness in the larynx. So this weakness in the larynx will cause outpoaching of the laryngocele. Not only that, in trumpet blowers, what the trumpet blowers will do, the trumpet blowers will create a more pressure in the larynx. Intralaryngeal pressure will increase in the trumpets. So this increased intralaryngeal pressure will cause outpoaching of the saccule or ventricle from the larynx, which is causing a swelling in the neck or swelling in the larynx, which is called as laryngocele. So the laryngocele is of three types. The laryngocele is of three types. See, this is called as external laryngocele. If the saccule outpoaches externally, what he is doing, what maneuver he is doing? Doctors, can anybody answer? What maneuver he is doing? Excellent. He is doing a Valsalv maneuver. Valsalv maneuver means closing the nose and blowing the air. 1 minute. So closing the mouth and blowing the mouth, it is called as Valsalv maneuver. It is called as Valsalv maneuver. In ENT, where you will do Valsalv maneuver? For which purpose you will do Valsalv maneuver? Where you will do Valsalv maneuver? In ear. In ear. Eustachian tube. Opening of the eustachian tube. When there is a retracted tympanic membrane, to prevent retraction or to make the tympanic membrane comes to its normal position, we will do the Valsalv test. And for eustachian tube function test, what is the name of the eustachian tube function test? Where you will do this Valsalv maneuver. Name of the test. What is the name of the test? Tony B test. What are the other tests other than Tony B test? What are the other tests of eustachian tube function test? Tony B test. Still, Pulitzer test. Still more. We'll use Pulitzer bag, Tony B test. Okay. Apart from Pulitzer test and Tony B test, what are the other tests? Next class, you have to answer what are the other tests of eustachian tube function tests. Okay. Okay. Temporometry. Okay, correct answer. Next question. Next time you have to answer all this question. There are many tests. There are 6 tests. Frenzel maneuver. Okay. Tony B test. Frenzel test. Okay. So this is a Valsalv maneuver. See, one question I'll tell you. All murmurs decreases with Valsalv maneuver. Only one murmur will increase in the Valsalv maneuver. What is the defect? What is the disease? What is the cardiac disease? In all cardiac diseases, I mean in all cardiac valvular lesions, the murmur decreases with Valsalv maneuver. but only one cardiac disease in which the murmur increases with Valsalv maneuver. What is that cardiac disease? Answer in the ending. Okay, so first answer in the ending, please answer in the last. Okay, all cardiac murmurs decreases on doing Valsalv maneuver, but only one cardiac murmur will increase with Valsalv maneuver. Excellent. It is HOCM. The only murmur which increases on Valsalv maneuver is HOCM. 17807108. What is the name? Please mention the name. What is your name? 17807108. Okay. So Meena. Okay. Wonderful, Meena. Good answer. Wonderful answer. Okay. So this is the Valsalv maneuver. Okay. So Valsalv maneuver is useful for seeing the external laryngocele, and it is also useful for seeing the combined laryngocele. I'll tell you what is external laryngocele and I'll tell you what is combined laryngocele. Internal laryngocele. Internal laryngocele will stay in the larynx only. It is between the false vocal cords and aryepiglottic fold. That means it extends, this sac extends from the false vocal cord above to up to the aryepiglottic fold. It is called as internal laryngocele. Then what is the external laryngocele? The external laryngocele is outpoaching of the laryngocele into the neck. It is called as external laryngocele. Then what is combined laryngocele? Internal laryngocele along with external laryngocele. If we combine both of these, it is called as combined laryngocele. So they'll ask the question, on Valsalv maneuver, the swelling does not appear in following laryngoceles: external laryngocele, internal laryngocele, and combined laryngocele. None of the above, all of the above. On Valsalv maneuver, the swelling in the anterior triangle does not appear in the following type of laryngoceles: external laryngocele, internal laryngocele, and combined laryngocele. Does not appear in the swelling does not appear in the internal laryngocele, because the swelling lies between the false vocal cords and the aryepiglottic fold. But the swelling appears only in the external laryngocele, and the swelling appears in the combined laryngocele, because in the combined laryngocele we combine both internal laryngocele and the external laryngocele. Okay. So this is the external laryngocele. This is the outpoaching of the saccule or ventricle between the false vocal cords and the true vocal cords, and it comes into the neck. It is called as external laryngocele, whereas the internal laryngocele extends from the false vocal cords up to the aryepiglottic fold. This is called as internal laryngocele. If you combine both of these, it is called as combined laryngocele. So no swelling appears in the neck in the internal laryngocele. Swelling appears in the neck both in external laryngocele and combined laryngocele. So clinical history will be hoarseness. There will be stridor. Okay, this is called as, if the manual compression of the neck swelling results in a gargling sound, it is called as yes, excellent, Bryce's sign. Here the spelling is here wrongly written. It is not Boyce's sign. You are able to catch that properly. 17807022. Name you have already mentioned. What is your name, Dr. Gar? What is your name? 22. What is your name? Name Sneha. Excellent. You are able to catch the mistake in my PowerPoint. There is a greatness in you. You are able to catch the mistake in my PowerPoint. Okay. Very good. Very great. So that gargling sound which is present on pressing the external laryngocele, that gargling sound which we hear is Bryce's sign, not Boyce's sign. Boyce's sign we'll see in where? Boyce's sign. Where should I mention this mistake? Boyce's sign. Can anybody answer? Boyce's sign. Pharyngocele. You have not answered. Excellent. It is juncus diaviculum. So the gargling sound on compressing of the juncus diaviculum, the gargling sound which we hear, it is called as Boyce's sign. But the gargling sound which we hear on compressing the laryngocele is called as Bryce's sign. Okay. Bryce's sign is for laryngocele. Boyce's sign is for esophagus. Boyce's sign is for esophagus. Bryce's sign is for laryngocele. But what is Boca's sign? Boca's sign. Boca's sign. B-O-C-C-A-C-S sign. Boca sign. No, 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 no. What is Boca sign? Boca sign. Yes, prevertebral. See, just flex your neck and you just move your larynx sideways. Then you feel a crepitus sound. That crepitus sound is because of rubbing of the larynx against the vertebra. This is called as Boca sign. So Bryce sign is for laryngocele, Boyce's sign is for juncus staphylococcus, and Boca sign is for moving of the larynx against the vertebra. In which conditions you cannot see the Boca sign? In which conditions you won't see the Boca sign? Whenever there is a post-cricoid tumor. That means if the tumor is present between the larynx and the esophagus, larynx and the vertebra, that is post-cricoid. This is the cricoid cartilage. Post-cricoid tumor, you cannot rub the larynx against the vertebra. So any post-cricoid tumor or any prevertebral infection or prevertebral fascia infection or prevertebral abscess or retropharyngeal abscess, this Boca sign cannot be elicited. So Bryce sign is for laryngocele, Boyce's sign is for pharyngocele or juncus staphylococcus, and Boca sign is for laryngeal crepitus. Boca sign is for laryngeal crepitus. Bryce sign is for laryngocele. Boyce's sign is for, how can you remember? Boyce's sign is for esophagus. See, E is in the Boyce's sign. So E is for esophagus. Bryce sign, there is no E. So Bryce sign is for larynx. So Boyce, E, E, Boyce's, esophagus. Boyce is for laryngocele, pharyngocele. Bryce sign is for laryngocele, and Boca sign is for crepitus. Okay. So the investigation of choice is flexible laryngoscopy, and the treatment of choice. So investigation of choice is you ask the patient to go for X-ray AP view, and you ask the patient to do Valsalv maneuver. Because of the Valsalv maneuver, there is a swelling in the larynx, and this swelling will give rise to this type of air-filled space in the neck. Air in the color, black color. Then radiolucent and radio opaque. Radiolucency and radio opacity. Is it radiolucency or radio opaque? It is a radiolucent lesion. So radio opaque is this vertebra, this skull, they are all radio opaque. So this radiolucent swelling which is seen on Valsalv maneuver is called as laryngocele. Okay, see on CT scan, this is the esophagus, this is a hyoid bone, this is the swelling. Is it, I'll give you this image, is it internal laryngocele or is it external laryngocele or it is a combined laryngocele? Can anybody answer? By CT scan. This is a combined laryngocele. See, this is entering into the larynx. See, this one is entering into the larynx. This is the thyroid cartilage. This is the calcification of the thyroid cartilage. So this is entering into the larynx, and there is external appearance also. So this is a combined laryngocele. Combined laryngocele. So treatment. The treatment is excision by external approach. If it is a combined laryngocele or if it is a external laryngocele, you give incision at the anterior border of the larynx, anterior border of the sternocleidomastoid, and you excise this laryngocele if it is combined or external laryngocele. Okay. Or if it is an internal laryngocele, you will do an endoscopic surgery and you excise the sac and you suture the remnant. You suture the remnant structure. This is called as marsupialization. So marsupialization is the treatment of choice. Endoscopic marsupialization is the treatment of choice for internal laryngocele. Whereas for external laryngocele, it is the external approach. External excision is the treatment of choice for combined or external laryngocele. See, this is the external approach. What they have done, they have given an incision in the anterior border of the sternocleidomastoid, and they have reflected all the structures, that is carotid vessels are reflected laterally. Then we will see the thyroid cartilage, and the incision is given in the thyroid cartilage, and we remove this tumor. We are not tumor. We remove this laryngocele by giving incision on the lateral surface of the thyroid cartilage. we excise the laryngocoele by external approach. Okay. Saccular cyst. Okay. The saccular cyst, just you remember only 1 or 2 points. This arises from the saccule or from the laryngeal ventricle because the name is saccular cyst. So that saccular cyst arises from the saccule. So it arises from the ventricle or from the saccule. 40% of them are congenital cysts. They are found within hours of birth. So what is the symptom? Most commonly, the symptom is inspiratory stridor, which improves during head extension. Why during head extension it improves? Because during head extension, the glottic space will increase. So because of the increase in the glottic space, the symptoms will improve. Okay, improve during extension of the head. Okay, there is nothing much to learn about the saccular cyst. This is the saccular cyst, which is smaller in size. So the treatment of choice is microlaryngeal surgery and excision of the. If this is a large size, it obstructs the laryngeal inlet and it causes stridor. So the treatment of this. See, this is a CT scan. CT scan showing the cyst, saccular cyst, which arises from the saccular space or from the ventricle. So the treatment of the choice is doing the first. If there is a stridor, we do a tracheostomy, and after doing the tracheostomy, by using the endoscope, we do deroofing of the cyst, or we can do marsupialization. What is marsupialization? Removing of the excess of the tissue and approximation of the remnant epithelial tissue is called as marsupialization. So we'll do endoscopic deroofing or marsupialization. The surgeries we can do cold knife. Cold knife means by using instruments like micro scalpel. By using micro scalpel or by using micro scissors, if we do the surgery, it is called as cold knife. And by using a laser assisted, it is called as hot surgeries. By using a laser assisted. So the treatment for this choice is, if the patient is having stridor, we will do tracheostomy to relieve him from the stridor. Then after relieving him from the stridor by doing tracheostomy, we plan for a staged operation. We can do deroofing of the saccular cyst, and or we can do marsupialization. Marsupialization means removing the diseased tissue beneath the subepithelium and closure of the remnant of the defect by using the remaining epithelium is called as marsupialization. And by doing this surgery, we can remove the saccular cyst. One more wonderful question I am going to ask you. De-roofing of the cyst in polycystic kidney disease. What is the name of the surgery? What is the name of the surgery called as de-roofing of the cyst in polycystic kidney disease? What is the name of the surgery? Name of the surgery, can anybody? What name of the surgery is there? De-roofing of the cyst in polycystic kidney disease. Next time when we come for the next session of the class, we can answer. Can anybody answer? Rousing's operation. Excellent. Rousing surgery. Rousing's operation. Rousing's procedure. Then what is rousing sign? Where you will see rousing sign? Rousing sign. You will see in acute appendicitis. Okay. In recording of an students of Malayalam. So we completed the benign lesions of the larynx.